Today, we'll be reviewing some of our common high-risk OB emergencies. The goal is to understand the pathophysiology behind our management. I want everyone to know not just what to do, but why we are doing it and why timing matters. Your job requires you to make decisions without lab work, without imaging, and without an OB next to you. That means you need to be good at pattern recognition, early treatment, and knowing when something isn't normal. But OB emergencies can be especially challenging because the physiology can be misleading. Pregnant or postpartum patient can have major blood loss and still look deceptively stable in the early stages of their disease process, which is why vaginal bleeding after delivery can't just be written off as expected postpartum bleeding, and why seizures aren't just seizures. Pregnancy and the postpartum status complicate the differential diagnoses. The critical postpartum time period we're worried about is up to 6 weeks. That is important because many of these patients might not think that they are having an OB emergency. The baby has already been delivered, they are home, and you, as EMS, might be the first to recognize that their headache, weakness, or bleeding is pregnancy related. Let's start with a case. You're dispatched to a home delivery, which is already my personal nightmare, but at least there's a midwife on scene. When you arrive, the baby has already been delivered. The placenta was delivered about 15 minutes before you got there. You find an exhausted looking new mother lying on the couch. She's awake and alert, but she's breathing a little fast, around 22 times a minute. The midwife called 911 because the bleeding has not stopped, even after the placenta delivered. You get a blood pressure of 114/68, heart rate is 123. You palpate the uterus and it feels soft and boggy. Is this patient stable or unstable? I would argue that this patient is unstable, or at least compensating and at high risk of rapid deterioration. What if I adjust the case and her heart rate was 110 and her blood pressure is 104/65? Does that make some of you feel better or worse? The point is that a single blood pressure number should not reassure you if the overall picture says hemorrhagic shock. Do not anchor on the blood pressure, and do not let a normal blood pressure fool you. Remember, in class 1 hemorrhage, the patient only has minimal findings: mild tachycardia, maybe a little anxiety, and the blood pressure is usually still normal. It isn't until class 3 hemorrhagic shock, after the patient has lost about a third of their blood volume, that you start seeing hypotension. In other words, hypotension is a late sign of shock. If you wait for it, you are already behind the 8 ball. The textbook definition of clinically significant postpartum hemorrhage is loss of at least a liter of blood. But realistically, no one outside of the OR is accurately measuring this. Even in the hospital, visual estimation of blood loss is notoriously inaccurate. What you can do and what you should do is describe what you see. Are there saturated towels? Is there blood pooling underneath the patient? Is blood continuing to flow? Is the patient becoming more pale? Is the heart rate climbing? Is the mental status changing? These descriptors, along with serial vital signs, are extremely useful to the receiving ED and OB team. The most common cause is uterine atony. After the placenta separates, the placental bed is essentially a large vascular wound. The arteries that supply the placenta need to be compressed by the myometrium. The uterus itself is supposed to be the hemorrhage control device. But if the uterus fails to contract, it can't tamponade itself and continues to hemorrhage. And in cases of uterine atony, you start with a fundal massage. How do you do a fundal massage? You place one hand over the lower uterine segment just above the pubic symphysis to support the uterus. Then place the other hand over the uterine fundus and massage in a firm, rotating motion, with the purpose of stimulating the uterus to contract. That contraction is what compresses the placental bed and reduces bleeding. You can also give oxytocin, which stimulates uterine smooth muscle contraction. Mechanistically, that contraction also compresses the placental bed and reduces hemorrhage. In contrast, TXA doesn't make the uterus contract, but why do we still give it? Remember that TXA is an antifibrinolytic. It helps prevent clot breakdown by inhibiting plasminogen activation. That means TXA helps preserve clot while you're controlling the source of bleeding and moving the patient toward definitive care. This is why timing matters. For immediate postpartum hemorrhage, the benefit is greatest when TXA is given early, generally within 3 hours of delivery. When it comes to resuscitation, a hemorrhaging postpartum patient is not that different from a trauma patient with major internal bleeding. The core problem is blood loss. You can support preload temporarily with IV fluids, but crystalloid does not carry oxygen. It does not contain red blood cells. It does not contain platelets, and it does not contain clotting factors. An unnecessary crystalloid can dilute the clotting factors that the patient has left and push them further into a coagulopathic spiral. So, establish access, support perfusion, but understand that IV fluids is a bridge. It is not definitive treatment for major hemorrhage. Let's move on to high blood pressure in pregnancy. Preeclampsia is a systemic endothelial process. Something about pregnancy causes the vascular lining to become dysfunctional and triggers vasoconstriction, capillary leak, platelet activation, and end organ damage. The blood pressure is a number we can measure in the field, but the disease process is much broader. The major signs and symptoms associated with the preeclampsia are severe headache, visual changes, right upper quadrant pain or epigastric pain, shortness of breath, chest pain, or altered mental status. The goal is not to make the patient normotensive, but controlled reduction with a goal systolic of 130 to 150 and diastolic of 80 to 100. We can't ignore severe hypertension, but we don't want to overcorrect it either. Let's look at another case. You're called for a patient who's 5 days postpartum. Family on scene tells you that the patient had a headache all morning, became confused, and then had a tonic-clonic seizure. You get a glucose that's normal and blood pressure that's 137/96. From this information, would you consider this patient preeclamptic? The answer is yes, absolutely. Any sort of new onset seizure activity during or after 6 weeks of pregnancy is considered eclampsia. This is usually taught as the extreme deterioration of preeclampsia, that is, what happens when blood pressure goes uncontrolled in a pregnant patient, but you can have eclampsia without severe high blood pressure. So don't rule it out just because the blood pressure isn't 180/110. Per our protocol, which is based on guidance from NAMSP and the American College of Obstetricians and Gynecologists, the first-line treatment is magnesium sulfate. This is different from routine seizure management. For most seizures, we think benzos, but eclampsia is different. Magnesium is the disease-specific treatment to prevent further seizures, but not necessarily stop the current one. It is believed to work by reducing cerebral edema through vasodilation. Benzodiazepines still have a role, but they are not the primary treatment for eclampsia. If the seizure does not stop, or if the patient is in status epilepticus, then treat the ongoing seizure activity with benzos. In real life, you're probably already handling all these things at the same time: airway positioning, glucose check, IV access, MAG, Versed, and blood pressure control. OB emergencies can be intimidating because we do not see them every day. But if you simplify them into basic physiology, they become manageable. Bleeding needs hemorrhage control, severe hypertension needs blood pressure control, and eclampsia needs magnesium and seizure management. And that's all we have for this episode. This is a production of Redfield Medical Direction. This episode was produced by me, Lin Win. The theme music is by Infraction. As always, don't hesitate to reach out if you have any questions. See you next time.